Hi, everyone. Thanks for joining us. We're going to wait about 1 minute while folks are coming into the webinar, and then we'll get started. Thanks very much for joining us. Well, welcome everyone. We have a great crowd here tonight. Thank you so much for joining us. I know it's a really tough time for families, but we're really excited to be here to talk to you about vaccination for children and to answer your questions. So I'll introduce myself first. I'm Dr. Becca Bell. I'm a pediatric ICU doctor at UVM Children's Hospital in Burlington. And I'm the current president of the Vermont chapter of the American Academy of Pediatrics. And with me, I have Dr. Josh Kantrowitz from St. Johnsbury Pediatrics, who is going to talk about the COVID-19 vaccine in children in 5 to 11-year-olds. I want to mention a few other things. We have an ASL interpreter, Patrick, who's here with us tonight, and we really appreciate him being here. And in terms of your questions, feel free to, in the Q&A at any point, put in some questions and we'll keep track of all of the questions and answer them at the end. So Dr. Josh will go through a presentation, which will probably answer a lot of your questions. That takes about 20 to 30 minutes. And then the rest of the time is just an informal time where we'll look at your questions and answer them. And they're all anonymous, so only we see the questions. So feel free to ask away. And we're really happy that you're here with us tonight. So I'll hand things over to Dr. Josh.
Well, thanks to Dr. Bell, and thanks everyone who's participating tonight. I'm Josh Kantrowitz, one of the pediatricians at St. Johnsbury Pediatrics. Many of you may know me or my colleagues at the office, and so thanks for participating tonight. I did want to thank everyone involved in making this presentation possible. I know there's a lot of questions from families. It's hard for me to leave a room during a visit these days without a family asking a question about COVID vaccine, either for themselves, their children, family members, or friends. And so again, it's good that we're able to present some of this information to everybody. Many of you may know or may not know that the pediatric community in Vermont has spent an immense amount of time trying to coordinate information and support each other. Working in a rural environment, we don't always get a chance to talk to other pediatricians, nurse practitioners, PAs, specialists in our busy days. And at least once a week, and early on in the pandemic, 3 times a week, we were meeting as the American Academy of Pediatrics with Dr. Bell as one of the leaders on that side. Stephanie Winters, who's here and is the executive director of the American Academy of Pediatrics, and organizes a lot of this work that we do. A number of representatives from the Department of Health and a program called VCHIP, which some of you may be aware of, which is a quality improvement project that works every year on improving the care of children in the state. This has been a team effort, talking amongst all of the people who take care of pediatric patients in the state. And it's really helped us stay on top of things that are changing all the time. We get new information about COVID, its effect on children. Even the way that the pandemic has affected kids has changed since the Delta variant has taken over as the prominent part of COVID. And so it's been instrumental in making sure that we all have up-to-date information and we're able to ask questions that are complex questions. Anyway, I wanted to just say that I appreciate all of the work that everyone's been doing in the pediatric community. I also just wanted to talk about the fact that with all of that cooperation, it has been meaningful in our own office, as you may come and see one of us and then see another one of us or one of the family medicine practitioners in our community. We do a lot of communicating, and we try to be consistent about the information that we are able to provide to you. And that's hard when the goalposts are sometimes changing, when new information is being presented. Anyway, it's been really helpful. So I'm going to talk a little bit about vaccine in children 5 to 11 for COVID-19. These slides are a little bit adapted or edited by me, but they're mainly the slides that are being seen by all of the community forums throughout the state over the last week and the next few weeks. So I'll share those right now. Sorry. All right. And as Dr. Bell said, if at any point you have questions, write those in and I'll be able to address them over time. So here's the main points of the topic tonight. We're going to say, we're going to address why children should get vaccinated. And if that's a question that you have, we'll do our best to answer that for you. What are we protecting our children from when we vaccinate? And what are the risks of vaccination? Because that's been on people's minds, certainly. So how do COVID vaccines work? COVID vaccines work like a lot of the other vaccines that we have, and part of pediatrics every day is vaccinating kids. We know that it's been a remarkable medical intervention to protect the health and safety of children for decades. It's the vaccines that are approved for children for COVID-19. The only one under 18 right now is the Pfizer vaccine. And the Pfizer vaccine is a mRNA vaccine. It essentially allows our cells to use a blueprint. That blueprint can produce a copy of what looks like the spike protein that's on the surface of SARS-CoV-2, the virus that causes COVID-19. And it allows our immune system to recognize that. It aids our immune system in being able to then respond if we are exposed to the virus at any point. We know so far that in patients 12 and above, from millions of doses of the vaccine being given, that the vaccine is effective at reducing the chance of getting COVID-19, and it reduces the severity of the disease, reduces the risk of being hospitalized, and so forth. So now we move into this period of time where we have the vaccine approved for 5-year-olds and above, and we're going to talk about that moving forward. So how effective are the vaccines? All the COVID-19 vaccines that have been approved and used in the United States have been shown to be effective. We know that they, like I just said, prevent serious illness, hospitalization, and certainly death as we look at the population, and certainly the highest risk members of our communities, people who with chronic health disease, health issues, and older individuals in our community. We don't know how long that immunity will last. There are studies ongoing right now, and it seems like every few days there's a new study that you can see in the news talking about immunity and how immunity from vaccines may continue forward. There's even some newer studies that came out recently about if you've had COVID-19 and then you get a vaccine and how that sustains immunity. So that research will be presented further and further as we move forward. How do we know that COVID-19 vaccines are safe? We have data that we're going to talk about today. We most recently have the research for the 5 and 11 group, and that was looked at in over 3,000 individuals who got the vaccine, compared with about 1,500 that got saline, a placebo. And we, over the course of the pandemic, not me, because I'm not a researcher for vaccines, but the people who are doing that work are monitoring frequently, all the time, to see what side effects or outcomes may be related to the vaccine as we move forward. This has been, as all of us know, a period of time in history where immense amounts of information can be gathered in real time. If anyone has a smartphone, if anyone uses social media, we know that information comes out as soon as it's happening in the media, and people are able to put information back into a system if they experience side effects and so forth, so that we're gathering data at a rate unprecedented in history. And that has allowed us to watch very closely for signals of potential side effects, and also to take a look at the effectiveness of the vaccine. This is the timeline for Pfizer vaccine. Again, the only vaccine that's approved in people under 18. So in December of 2020, it's when there was original emergency use authorization for the vaccine. And then moving forward, May was when it was approved for 12 to 15-year-olds. It was originally approved for 16 and above. And then in August of this year, full FDA approval was given for 16 above. And then, as we all know, the reason we're having this conversation is that in the beginning of this month, full approval, well, it started being rolled out that vaccine can be used for 5 to 11-year-olds based upon research that was conducted in this age group, and has been available starting as of 2 weekends ago in Vermont. So we have seen an immense number of vaccine doses given in the United States over the period of time since last December, 100 million people. And we know that over 12 million youth, 12 to 17, have been fully vaccinated as well. So, originally those studies came out in thousands of people, and now we have millions of data points for us to look at to assess what the effectiveness of these vaccines have been, and if there are any side effects or concerns related to them. It's important to know how the vaccine is different for kids 12 to 15 than, for kids 5 to 11 compared to older children. The most important detail there is that it's a smaller dose. The dose for older individuals is 30 micrograms, and the dose that's given to 5 to 11-year-olds is 10 micrograms, so a third of the dose. The researchers who did this took a look originally at whether the immune response, antibody response, was equivalent based upon those two doses, and it was evident that at 10 micrograms, youth in that 5 to 11 age group did have a robust antibody response. And then they moved forward with the studies to take a look at how effective the vaccine was in stage 2 and stage 3 of the trial. In that stage of the trial, when efficacy, how effective the vaccine was looked at, it was about 90 to 91% effective at preventing COVID-19 infection. And this also happened, it's important to know, partly into the Delta wave. So we had data looking at the most recent environment that we find ourselves in related to COVID-19. Whereas the prior vaccine studies, when we were looking at the older age groups, 12 and above, we hadn't seen the Delta variant hit to the degree it has since midsummer. And so those were really looked at, looking at prior variants of the virus. It's important to know that in the study that was done, that was just reviewed, that there were no serious adverse events in children. It was a study, again, conducted with 3,000 people who had received the vaccine and 1,500 that had the placebo. This is just a diagram looking at how the vaccine study was done. So phases 1, 2, and 3. In phase 1, they were looking at the dosing. So looking at 10 micrograms, 20 micrograms, 30 micrograms, checking to make sure that the immune response was effective. And then once that was identified, moving on to phase 2 and 3, looking at the effectiveness of the vaccine to prevent the virus. The randomization, so if you take a look, if I can find my pointer here, taking this group of individuals, 5 to 11-year-olds, randomizing them to a group that got a dose of the vaccine and then another dose 3 weeks later, or getting the placebo in the same way. And again, looking here at whether the vaccine was effective at doing its job and following any safety data that was related. So, what are the side effects of getting the vaccine? A lot of people have asked this when they come into our office. Some people don't have any side effects at all. And the most common side effects are local responses. So where you get the shot, if any of the adults who are listening in got the vaccine, whether Pfizer or Moderna or J&J, you probably experienced some local pain or tenderness to the vaccine, or swelling or redness. And that's fairly common in youth as well. Then there are the symptoms that many of adults have shared with me that they had, including myself after my second vaccine, feeling headachy, sore, feverish, chilled. Some people have those symptoms for a day or more, and some people have very limited symptoms, and some people have very few. What is interesting, and one of the reasons that youth were tested with different doses, we were looking for whether at different doses children would have less side effects and at the same time have the same efficacy, the benefits of the vaccine. So it is true that younger people in this age group, 5 to 11, have less of those generalized symptoms, those chills, fever, headache, muscle aches and pains. And I'll show you a slide that reviews that. These symptoms all go away generally fairly quickly. I don't know what your experience was. Mine was a morning where I felt fairly miserable. We've done a little mini poll in our office, and certainly in the adults who got vaccine, which was all of us. Some of us had no symptoms. Some of us felt pretty crummy for a day and a half. On average, it was less than a day. So this is the data on kids. So this is the local reaction data. And you can see that if we take a look at dose 1 and dose 2 of the vaccine, and we're looking at this 10 microgram dose, because this is the dose that's being given in kids 5 to 11, we can see that redness and swelling, most kids experience that, well, not most kids, some kids experience that anywhere between about 14 to 18%, with the redness, swelling 10 to 15%, but pain, most kids feel. So if you look at the 10 microgram dose, about 3/4 of kids will have pain. And then there are some that have no symptoms at all. They don't have much pain at all. If we jump to the more systemic symptoms, you can see here again, we're looking at the 10 microgram dose, and this is getting the vaccine versus getting the placebo. So in terms of fever, not super common, about 6%. Compared to older individuals in the 15 to 25-year-old group with 30 microgram dose and about 17%. But in young people, we do see about 40% get fatigued, about a third get a headache, some have chills, about 10%, and then muscle aches and pains, again, at about 10 to 11% here. So far less than adults, but still, kids experience those symptoms generally in the first 24 hours after getting the vaccine. What about myocarditis? This is the biggest question we get at our office about the side effect, because this has been fairly public, the information that's available on side effects from vaccines in kids 12 and above. So it's important to recognize that the study done on 5 to 11-year-olds showed no cases of myocarditis. This is expected because it is a very rare side effect of the vaccine. And in 3,000 people, we would not expect to see that as a significant side effect. However, as we're looking at the data coming from 12 to 17-year-olds, certainly there has been an increased risk of myocarditis. It is very small, but it's generally seen in children 12 to 17, males, And generally, the older the male is in that age group, the higher the likelihood. So it's really 16, 17, and 18-year-olds who have experienced the higher rates of that. And you can see at the lower part of the slide here, it's extremely rare. We're looking at, 1 in 10. Sorry, I can't see the slide behind the people here that I'm looking at, but 1 in 10,000, 0.01% of the cases. And as you then go down in age, down to the 12 to 15-year-olds, far less. There's been a number of hypotheses for why this is true. It does not seem to be a higher risk for females who get the vaccine. And the hypothesis on this, specifically coming from cardiologists and specialists who are looking at this, is that it may have to do with the hormonal changes that happen in males as they get older, because this signal, this increased risk, is noted in young men also up until about age 30 in the research. I think it's important for us to recognize why, when it has been recognized that myocarditis is a very, very small risk with the vaccine, why we're still recommending vaccine. And the most important detail there is that the disease causes myocarditis for a number of kids. And we'll get on to this point, but it's really also important to recognize that the highest risk kids to get myocarditis are the age group we're talking about tonight. So the 5 to 11 age group is the group that when they get a complication from COVID-19, and specifically some of them with this condition called MIS-C, which I'll talk about later, myocarditis is high risk for those individuals. And so we're hoping to prevent the cases of myocarditis that are higher risk in people who get the disease. In addition, although this gets down to some of the fine details around myocarditis, when you get myocarditis from the vaccine, these very few cases, the cases are very short-lived. On average, they're 1 to 2 days of hospitalization monitoring children. The cases resolve almost exclusively very quickly. And if you look at the myocarditis cases, people who get the disease, those cases last longer and are more severe. Most of them resolve as well, but those children are often hospitalized for 5 or more days with their myocarditis cases. And Dr. Bell, who's a specialist in intensive care, could talk about that if people had questions later. But her field is really the group of people who are taking care of these sickest kids with myocarditis when they're getting to the hospital and admitted to the hospital. So when we're making any decision in medicine, and any family who's met me and spent time with me in the office, if they ask me a question about why I recommend either a test or an intervention or an antibiotic or some other medicine, I'm always talking about the fact that we're trying to make a decision on risks and benefits and trying to balance that. And what we're always trying to do is come up with a benefit that outweighs the risk. And if we can find that balance, that's the thing that we're going to try to advise parents on. If we can say the benefit is here and the risk is lower, and this situation, this might be the best decision for your child. Every parent has to make that decision for themselves. And we talk about that all the time in pediatrics. But our role is to be partners with you in terms of helping your children be as healthy and safe as they can be. So some people have also asked about the late onset side effects of a vaccine like the COVID vaccines. What could happen down the road if my child gets this vaccine and in a few years we recognize that there's some potential side effect from the vaccine? This is a crystal ball question. I recognize that none of us can look into the future. We can only base our decisions based upon the research that we have and the data that we have. And what we can say is that when you look at the history of vaccine and you look at how vaccines have been studied, the side effects that come from vaccines, which have been documented over time. I was watching a webinar that Dr. Bell and Dr. First, who's the head of pediatrics at the UVM Medical Center, and the publisher or sort of the editor of Pediatrics, the largest pediatric journal that all of us follow. They were talking about the fact that looking at decades of research around vaccine, we have never seen a point in time where a side effect from a vaccine has shown up more than 8+ weeks after vaccines have been given. All the side effects generally are recognized early. And so, as we've been following the potential side effects from the COVID-19 vaccine, we certainly recognize that with that very detailed monitoring, we have seen this potential, this real increased risk of myocarditis in very rare cases. But we haven't seen any other potential side effects in now months and months of data following individuals. And so that's important to know. All right. What are the risks of COVID-19 infection in children 5 to 11? So I've already touched upon this a little bit, but I will continue on with some information, some visuals. So if you followed any of the national data, you know that there have been more than 8,000 children hospitalized with COVID-19. When you get hospitalized with COVID-19, it is fairly high risk that you will need intensive care. And that is when you step up from being monitored generally in a low risk setting to a situation where we consider you to be a higher risk patient in the hospital and may need more intensive nursing care. So maybe a nurse that's one-on-one with you, that you have IVs and other things hooked up to you that may help you either breathe or get the nutrients that you need if you can't eat or drink. And in the worst case scenarios, situations where children might need intubation or assistance with breathing. And again, as I mentioned before, this is where children who might develop this MIS-C condition would be generally cared for because of the seriousness of their condition. So this is looking at the group of children that we're talking about, 5 to 11. And this is CDC data that talks about deaths by age group. There have been 94 deaths as of October 16th. So this isn't the most up-to-date data. But in this age group, that is what we've seen. You can see that the highest risk is young children under the age of 1. And as we move up to the adolescents, a higher risk. In terms of Vermont data, it's important to look at, this is number of cases by week. So this is the time that we all felt good right here. So we'd gone through our winter, our spike in the spring, and then it seemed that cases were dropping dramatically. And this is where we stopped wearing masks. People were feeling more confident about low rates of the disease. And I think all of us are aware of what was happening right here, which is this is when the Delta variant really hit Vermont. And cases went way back up. And as everyone knows right now, we are at some of the highest rates of virus in the state, or we're at the highest rate, perhaps, that we've seen throughout the whole pandemic. And we've had some of the highest case counts per day that we've seen throughout the entire pandemic. If we take a look over here on this side in terms of how the virus has affected children during this part of the pandemic, again, this represents our lull where we had very, very few cases in June into the beginning of July, and then Delta hit. And you can see by different age groups, blue is the 0 to 5 age group. This maroon color is the 6 to 11, and this greenish color is ages 12 to 18. You can also see that in this bar graph, as we see the cases have risen in children, this group of 6 to 11 represents a fairly significant part of that group. Another way of looking at this is just overall cases of children. And this graph represents the total number of kids who've developed COVID-19, tested positive for COVID-19. Again, here's our lull. And then as we move forward, you can see the spike that we've had currently. This is a graph that represents the rate per age group. So once again, want to highlight this group of kids, 6 to 11, who are currently having COVID or developing COVID and getting the disease at a higher rate than their peers at the adolescent age group and 0 to 5. One other way to look at this, and I just wanted to highlight it in terms of how people often look at the cases. We've been following this throughout the pandemic. This is a bar graph looking at different age groups, 0 to 9, 10 to 19, 20 to 29, and so forth. You can see that the highest caseload has been in people 20 to 29. When we look at this graph, and this may or may not be helpful, but you can see that in these two periods of time, going back to May and then looking at the most recent data, these two sections, 10 and up, look kind of similar in terms of the bar graphs. But if you look at the bar graphs for the 0 to 9 group, you can see that the relative increase in cases has been much more significant in the 0 to 9 age group. And quite clearly, we know that that's the age group that has had the least opportunity or no opportunity to get vaccinated up until this point. And although we can't draw a direct causative line to that, one would say that it makes sense that without that protection, they'd be at higher risk for getting the virus. There's just one other way to look at the cases for children in Vermont. So you can see down here, this Vermont represented compared to other states. And in terms of total numbers of cases, we per 100,000 children, we have a relatively low case rate up until this point. This is a map looking at vaccination rates and looking at eligible children, 12 to 17, before the most recent approval for 5 to 11. And you can see Vermont has done quite well in vaccinating our youth at about 81%, tied with Massachusetts, Rhode Island, and Connecticut down here also at higher rates of vaccination compared to the rest of the country. So why do we care about COVID and how it affects youth? Well, probably the most common presentation for people requiring hospitalization would be progression to pneumonia and lung disease. Those children, if they're sick enough, would need the intensive care unit management and possibly support from a ventilator or other machines that help provide pressure for us to breathe when we need support. There have been higher rates of hospitalization for adolescents who are unvaccinated compared to vaccinated. That rate in national data is 10 times as significant in unvaccinated adolescents compared to their peers who've received the vaccine. Luckily in Vermont, we've had fairly low hospitalization rates, and currently it may be different as of this week, but as of last week, I think we'd had 10 hospitalizations so far. So this is the multi-system inflammatory syndrome in children that I was talking about that mostly affects younger children. It basically represents an inflammatory process in the body. Prior to COVID-19, most pediatricians in their training and their experience would have, and all physicians who trained would have learned about a disease called Kawasaki disease, which we were always taught we didn't really know why it occurred, but we knew what the symptoms were. And it was this complex picture of kids who had prolonged fevers, they had conjunctivitis, they had swollen lymph nodes, they had a really sore looking throat and sometimes a rash. And when they developed this pattern of illness, they had a high risk of developing inflammation of the heart and potentially aneurysms of their blood vessels that go to their heart muscle, the coronary arteries. So everyone knew that this was a pretty severe and concerning thing. And when this was first recognized as the pandemic progressed, and Dr. Bell can correct me on this, but I think the first time we really recognized this was in New York City, as a huge number of people were getting the virus and a lot of children were getting it. And then a number of weeks after getting the virus, children were showing up at the hospital with what looked like this condition called Kawasaki disease, sometimes with other symptoms, including their digestive tract, which is not generally seen in Kawasaki disease. But these were really, really sick looking kids, and often required significant hospitalization. And sadly, close to 1% of those children die from getting MIS-C. And this is just a bar graph to show you which age groups are most affected by MIS-C. And you can see it's the age group that we're talking about today, 5 to 11. So when the approval process was happening for the Pfizer vaccine, really the discussion was around how do we balance out the pros and cons? What would we be doing in terms of preventing disease in children if we give the vaccine, and balancing that against potential side effects of the vaccine? And you can see here a representation of looking at females and males. For every 1 million doses of vaccine given, what would be the expected benefits? And so we're looking at benefits of preventing cases, how many hospitalizations would be prevented, preventing MIS-C cases, because we're talking about this age group, which is highest risk, and ICU admissions. Taking a look at those benefits, again, we're really looking at all of the things we just mentioned balanced against the risk of myocarditis or pericarditis, which is myocarditis is inflammation of the heart muscle. Pericarditis is inflammation of a tissue that wraps around the heart called the pericardium, and how that would affect hospitalizations, ICUs, and potentially death. As I've already mentioned, the hospital stay for vaccine-associated myocarditis is 1 to 2 days in the studies and is limited and generally very quickly resolves, and those cases are more mild. So the study did not look at whether SARS could be passed on from individuals who got the vaccine. So an endpoint to the study, it's always important to recognize what the studies show. And so what this study showed was, what was your risk of getting the vaccine, getting the virus, and what were the risks of complications or side effects? What it did not tell us was, did it reduce the risk of passing on the virus to other people? Although we could extrapolate that if you are less likely to get the virus, you are less likely to pass on the virus. We don't have that data specifically from the study. And then it did not look at what a lot of people are looking at right now, which is if you do get COVID, specifically, what are your outcomes as an individual? How many people have long symptoms from COVID, and how does it affect your future health? The FDA approval process had to answer this question specifically. Did the benefits outweigh the risks for children 5 to 11 years of age? And that was the decision that they were voting on. Some people have asked why the vaccine is based on a 10 microgram dose for all kids as opposed to based upon their weight. And I think I've already gone through that, but it's based upon the original way the study was done and looking at whether children in this age group developed a strong immune response. It's different than the way that we approach things with things like antibiotics, where we dose it based upon your weight. And then just to let everyone know that under the age of 5, there are trials going on from 6 months up, and we don't know when those studies will be available. The outcomes will be available. It'll probably be a number of months still. And in that age group, although I don't know this data, I haven't looked at it, the smaller doses, probably even than the 10 micrograms are being looked at. What about getting other vaccines at the same time? This is a really common question for families. They're calling us all the time about this, specifically because a lot of families are looking into getting the flu vaccine for their family. And this has been looked at. It is safe to get other vaccines around the same time. And specifically, we don't want to delay other important vaccines that kids can get. The flu, most importantly, last year we had very little flu around the country and almost no flu here in Vermont. Based upon what we've seen with other viruses in Vermont, everything from RSV to common cold viruses to the typical things that circulate in the summer, things like hand, foot, and mouth disease, we've seen those back. And they seemed to disappear last year, but as we've had more interactions in our society, those viruses are spreading. And so it would be likely to think that the flu will do the same thing. So we're concerned that we're going to see a winter where COVID is still active and the flu becomes active again. And we're dealing with those two serious health issues at the same time. Everyone should remember, I think we've talked about this before, but that it takes 2 weeks to develop immunity after the vaccine. So right after you get the vaccine, it does not mean that you're immune. Your immune system needs time to build up that immunity. So children are considered fully vaccinated 2 weeks after their second dose of the vaccine. And the second dose is spaced 3 weeks after the first. So essentially 5 weeks after your first dose is when we consider you to be fully vaccinated against COVID-19. In Vermont, COVID vaccines are free, and there are lots of opportunities to get vaccinated. You can look at the healthvermont.gov website. There is a ton of good information there, and register or get further information on the vaccine if you're interested. As you can see here, there have been school clinics ongoing this week. There are vaccination sites in the community, including at the local mall here in St. Johnsbury on weekends. And then some practices have vaccine, although with the demand that's been shown in Vermont for this age group, that's rolling out slowly. So for instance, our clinic does not have vaccine yet, and we certainly will make it known to the public when we do, but we don't have it available yet. And here are some there's some more information just about school clinics and registration. Here are a few important resources. Again, this is all being recorded, so if you need to come back and take a look at this, go for it. I will highlight the one website there. So healthychildren.org is the website from the American Academy of Pediatrics. That's for families and for caregivers who take care of kids. And they have an immense amount of information about COVID-19, and it's really easy to access. Most of them are one-pagers. You can put the kids to bed. You can actually take the time to read it and do it in a few minutes and not feel like you need to spend a half an hour reading a full article, but it gives you more information on where to get to if you want deeper, if you want to dive deeper into that data. And here are some kids. I will just say, obviously there is a very big, there's a vast spectrum of where people are at with their comfort level on vaccine right now. We have families coming in 100% interested and can't wait to get their vaccine. And we have kids doing, saying the same thing. The kids here on the right side of your screen clearly are excited about their vaccines with their Band-Aids there. And we know that there's a large group of families who are curious and questioning and wondering about whether vaccine is right for their kids right now. And we know that there are families who are really concerned about vaccine and are not planning to vaccinate their kids. But this is why we want the information out there, and we want to be able to provide as much information as we can. So thanks for listening. I really appreciate your time, and ready for questions that you might have.
Thank you so much, Dr. Josh. So we have a bunch of great questions rolling in. So I might give you a sec to catch your breath and answer a couple that I see, and then I'll have you answer some questions. So there are two that I wanted to address, some that kind of go along with some misperceptions of the vaccine. So one, and this is, I'm so glad somebody mentioned this because this is really a very common misperception about mRNA. I feel very equipped to answer this question because I actually used to be a biology teacher at St. Johnsbury Academy. And I think Dr. Josh was a biology teacher as well, pre-medical school. But so the question is this vaccine, can it change your genetics? Is it a genetic vaccine? And so what we know about mRNA, messenger RNA, is that it enters the cell along with like hundreds of thousands of other pieces of mRNA. That's how your body sort of communicates with each other. But it doesn't go into the nucleus, and the nucleus is where your DNA is, where your genetic material is. So it never goes inside the nucleus. Um, and in fact, one of the challenges with mRNA vaccine is just to keep it around in the body long enough to actually give the message it needs to give, and so it disintegrates really quickly within hours to days, and so that was one of the challenges actually, and so it is not something that gets into your DNA and changes any of your genetic material at all. And Dr. This is such a common question. I don't know if you, Dr. Josh, have other thoughts on how you explain that to families too.
Yeah, no, I mean, I think you addressed it. I think most people in their science classes know that DNA and RNA are related. And I think that, so that I think leads to some of the misconception about it, that if the word RNA is in the vaccine, isn't that sort of adjusting our genetics in some way? Um, and uh, the world of scientific research is really complex. There clearly are studies looking at how to create genetic therapies, but those have nothing to do with what the mRNA vaccine does. Um, my son was just taking his biology class on how the cell works. And he was talking about this ribosome, which is kind of like the factory where RNA comes in and the proteins are made based upon how the cell teaches, or how the cell takes that little spot, that little sort of factory, and reads the RNA, the blueprint, and sort of makes the protein so the protein can be used in the body. And that's something we do every second of our life all the time. This is the basics of biology, and how things work. So yeah, and in the place where our DNA sits, like you said, is right in the nucleus, and that's not where the mRNA goes. So it is a common question, but I think the misconception essentially comes from uh, the fact that when we learn in science about these two things, we know that they're connected, DNA and RNA.
How soon after testing positive for COVID can a child get the first COVID vaccine? Another very common question we're getting these days.
Yeah. So, I mean, in this situation, I think people are asking this because we have more cases. And certainly in our community, we've had far more pediatric cases than we've had at any point in the pandemic. The current feeling is really based upon trying to make sure that we're not infecting anyone else. So everyone should be quarantining for 10 days during the period of time when they are infected with the virus, because we know that that's the period of time when you're most infectious. And then infection risk drops off essentially to zero after 10 days. The only situations where that's not true is in individuals who are immunosuppressed. So for some reason you have an immunodeficiency or complication with your immune system, you should be really consulting with your physician, and possibly in a specialist if you have an immunologist about when you can get back to routine. But in people who have healthy immune systems, we know that you're not contagious after 10 days. So we don't want people going to the vaccine clinic while they're infectious to infect anybody else. We also want people to really recover from the acute phase of the illness. And the feeling is about 2 weeks after being sick with COVID-19, you could then get the vaccine. And that's important to then build your immunity further. There again have been some studies, not specifically focused on this age group, because that I'm aware of. Dr. Bell may know something different, but in older age groups, that if you do get the vaccine after you've had COVID, again, it boosts up your immunity, your protection against the virus significantly. And so that will hopefully prevent reinfection down the road. Again, I presented a slide that said we don't really know how long that immunity lasts yet, but that is the current data available.
This is a great question. What concerns could there be for vaccinating a child that was born prematurely? Is the body mature enough for the dose of the vaccine? And I'm sure this is a great question about COVID, and I'm sure you actually get this about with your patients about all childhood vaccinations. How do you think about children who are born prematurely?
Yeah, no, this one I think is a really interesting one because certainly there are some individuals born prematurely who have chronic health issues related to their prematurity. Dr. Bell, I'm sure, sees a number of these patients in her ICU, unfortunately, as they get older. So perhaps the highest risk for some of those patients might be that they have chronic lung disease from being premature. And in some of our most premature patients, they may have oxygen that they need, especially when they're younger, and may even have something like a tracheostomy that helps them breathe in certain cases. What we know about hospitalization for children who get COVID is that there are certainly much higher risk patients for hospitalization, and those include patients who have chronic lung disease, immunodeficiency, chronic neurologic disorders, and obesity. And another category for children who are born premature is that some premature children do have some chronic neurologic conditions, including cerebral palsy or other neurologic conditions that are related. So, again, those are some of our patients who are higher risk for complications from COVID. And when they get to the appropriate age, we would certainly want them to be vaccinated because what we're hoping to prevent is hospitalization. As we mentioned in that data, for older children, 12 and above, the vaccination reduces your risk of hospitalization. Um, there isn't any clear evidence that I'm aware of that children who are born premature, unless they have a specific condition, have any weaker immune systems. Their immune systems are strong when they get older, and they should be able to manage the vaccine like anyone else, and develop an immunoresponse to the vaccine. That would mean that they have protection. Um, so that's my initial thinking about it, unless there was a more specific question on that point about a condition related to that prematurity.
Well, there's another question that's sort of related, and you had mentioned cerebral palsy, and somebody asked, um, were in the Pfizer study for the 5 to 11-year-olds, were there any existing conditions like cerebral palsy or autoimmune disorders among the study participants? I'll add that I was trying to look that up on the side, and I know that they do, especially initially with the adult population, really did get people with underlying conditions. I don't know the breakdown in the Pfizer group, but it bears the same question: is if you have a child with with these examples, prematurity or cerebral palsy, autoimmune disorders, how do you think about vaccine and COVID-19? And I will say those are the children that I worry more about getting COVID-19 infection and getting really sick from COVID-19 infection. And we don't have any concerns about the vaccine, you know, among that group. So those are the patients that I really even more strongly recommend. And no one's asked this question yet, but oftentimes in other forums they ask about kids who have heart conditions,
Hmm.
and the pediatric cardiologists here and across the country, they're really telling their patients who have cardiac conditions, who are children, definitely get the vaccine because the infection, they worry about how the infection might affect the child. So I don't know if you have other things to add about just special populations within the pediatric population, how you think about vaccine and the COVID-19 infection.
Yeah. So going back, I don't have it right in front of me either, and I'd have to look on a different screen. But I do know in the study from 5 to 11, I think kids with some chronic respiratory issues, specifically asthma, were included. And certainly there were children who had the elevated BMI or obesity risk that were in the study. I don't know about cerebral palsy specifically and other chronic neurologic disorders. Again, I would have to look it up, but I remember looking at the breakdown of the data, and certainly respiratory illness was included there. Um, you know, this is your field, Dr. Bell, but we do know that two-thirds of the children who have been admitted to hospitals are carry some chronic medical condition. And I talked about, kind of the top of that list. But we know having some form of chronic health issue does significantly increase that risk. We have not, luckily, had a lot of hospitalizations in our state, but looking around the country, that's what we know. So I don't have much to add. Certainly, kids who have chronic heart disease, specifically the type of heart conditions where they are born with differences in the shape or structure of the heart, we know that those children, when they get any kind of virus, respiratory virus, often are much higher risk for being admitted to the hospital, and I think often end up in the intensive care unit where Dr. Bell takes care of them.
And to put a finer point on that, the clarification on the question was, say you have a child who's born premature, who just turned 5, so is just barely age eligible and has a heart condition. Would you recommend the vaccine? And specifically, the question is around the immune system response. And what I would say is absolutely, I would recommend the vaccine in that case, because I think there may be a little bit, if there's a heart condition, there may be a little bit more risk for COVID-19 infection. And we don't worry about, kids' immune systems are really pretty robust. And for those who have an immunodeficiency, what we worry about is that they just don't mount a response. So not that the vaccine is dangerous to them, it's that they get the vaccine, the body might make the spike protein and the immune system's like, I'm not going to do anything really with that. And they don't mount a good response. So it's not dangerous, it just may not be as effective. I don't know if you have other thoughts to add to how you think about that.
Right. So I don't know if I may have misspoke, if people interpreted what I said as meaning that if having an immune deficiency, that puts you at higher risk for complications of the vaccine. That's not true. Vaccines are not always as effective in people who have immunodeficiencies, exactly what Dr. Bell just said. I would add to Dr. Bell's point that so many people, when they have a chronic health condition, really trust their specialists. I know many families who see their neonatologist and follow up far more than they see me, certainly early on, or have great faith in their cardiologist or neurologist and so forth. And one of the benefits of this pooled pediatric experience that we've had during the pandemic is meeting with specialists frequently. 2 of the infectious disease specialists at UVM almost always are on our call. We frequently have the cardiologist participating and other specialists. And so, if you have a specific concern and you want to talk to the people that you trust, I know that some of the specialist offices also are fielding those calls. If you say, I don't know about the risk for my child, I would like to know what my cardiologist has to say. I think that they have not to flood their phones because everyone is busy. But I know that they have agreed with the points that Dr. Bell and I are making on the calls that we have with them about protecting kids who have high risk medical conditions. And I have had a lot of families who call the office and just say, hey, I just want to hear what Dr. Flyer's opinion is about COVID vaccine for my child who has congenital heart disease. And Dr. Flyer he's a cardiologist at UVM, but he's been on a lot of our calls and is really very supportive of doing whatever we can to prevent kids from getting COVID in that condition. So just to add to what you said.
There's a question here about the buffer that's used in the vaccine. So this is tromethamine. It's an inactive ingredient that's used in the vaccine that actually helps it, so that pediatrician offices and family medicine offices can have the vaccine. Is that something to worry about at all? You're muted.
I'm muted.
There you go.
So this people wondered about this, like why the vaccine that's come out for 5 to 11-year-olds has a different buffer than in older kids. And the buffer, to clarify, we all live in an acid-based state. If you go back to your high school science, acid is always in balance with this alkaline state. And we live close to the middle. The mRNA molecule does not like to be really alkaline or basic. So in order to keep it stable, in the vaccine, it needs this buffer, which is acidic, and that's what's being used. It's used in other medications that are given to pediatric patients, and it serves that purpose. So it's an inert substance, and again, has been used in other medical interventions. So we, feel that that's a safe substance to be finding that buffer for the vaccine.
And yeah, and I'll just add to that because somebody asked this. There is a lot of misinformation about this buffer that you can find in some parts of the internet, and there's this connection with a concern that it's given to people who are having heart attacks. And I won't get into the whole thing, but I believe that connection is with something called THAM, which we don't actually really use for people who are having cardiac arrest, but that's this kind of connection, and they're really not, basically they're not at all related. But I know that's a headline that some people are seeing in some in some sources, and so I wouldn't worry about that at all. It's completely not even the same product. um, there's a question here about really just clarifying that there weren't any adverse reactions in the 5 to 11-year-olds. So, and I can add, because I love this detail, that so, these studies are really carefully monitored. And so anything that happens to kids during the study period gets reported on. And so both in the placebo and in the vaccine group, there was no adverse events that happened related to the vaccine, but there's stuff that happened to kids during that time. So I think one kid in the placebo and one kid in the vaccine group both like broke their arms because they're 5 to 11, and one kid in the vaccine group swallowed a penny, which kids in this age group do. So you think it's toddlers, but no, it's school age kids too. They will eat money. So all of that was reported out, but not to be felt related to the vaccine at all. And Dr. Josh went through the systemic side effects that we see, which are less so than the 16 to 25-year-olds, which is helpful. There's a question here that I love because it's sort of reflective of my family right now. So someone said, okay, the vaccine's approved for a 5-year-old, but not a 4-year-old. What's the deal with that? And you sort of talked a little bit about that. And there is probably going to be the 2 to 4-year-old data is probably going to be submitted by the end of this year. And it's going to be a smaller dose. So it's possible that that age group will start to be able to be vaccinated by the end of January or early February. And, so I have a just turned 6-year-old and a 4.5-year-old. They're only a year and a half apart. So my 6-year-old was able to get vaccinated last week. My other child has not been able to because they're only 4. So how do you talk to families who throughout this, right? You probably had adolescents who were vaccinated with younger siblings who couldn't be. And so how do you talk to them about navigating this time when some are able to be vaccinated and some are not?
Yeah, well, I think there's a few different things on that as a part of that conversation. One, when the vaccine was approved for 12 and above, I had a 13-year-old and an 11-year-old, so it's a similar situation. And so our daughter got vaccinated, and then when our son turned 12, he got vaccinated, I think within 3 or 4 days. One component of that is recognizing that we don't want to extrapolate data that hasn't been presented yet and say that this is safe if we don't have research looking at it. So we do want to target the patient population for which the vaccine's been studied. So if it's been studied and the data's been presented in 5-year-olds and above, we want to say, this is what we know about 5-year-olds and above, and that's the information we can provide for you. Again, I said this before, we see our role in our office as being partners in helping keep your kids healthy and safe. And so we want to give you the most accurate information we can. If I was to jump the conversation to something else, people have been talking about monoclonal antibody for treating COVID-19. And there is an emergency use authorization for monoclonal antibody in people 12 and above, but we don't really have a lot of data in people 12 to 18. So when people ask me, what do you know about that age group? I can say, we know a lot of information about older individuals, but we don't know a lot of information in that younger group. So we don't want to give you information that we don't have. So number one, I think in answer to that question, we do want to give you accurate information. So we have studies from 5 and above. This is why we're recommending it, and we don't want to go off label to give vaccine to someone who doesn't meet that age criteria. Number two, I would say that if we can get people vaccinated who are eligible, hopefully we're blocking the transmission of virus to people who are more at risk. And those are now kind of our younger population who may not be able to get vaccinated yet. So within families, we often talk about this when people have a new infant in the household, and we're talking about flu season and trying to cocoon children who might not be eligible for flu vaccine yet. We want other members of the family to get vaccinated so that hopefully we block the transmission of flu in the household. I think that's the best we can say at this point, is to, let's try to get people protected when they can get protected. And then we await the data and the research that's coming.
Next question. Is there any known adverse reaction after vaccination in children with ADD or ADHD? I'll start by saying there isn't any that I've seen, and remembering that right now we've had about 13 million adolescents who have been vaccinated in the US, which is a lot with the Pfizer vaccine. And I'm going to add on to that. What do you recommend, Dr. Josh, for children who have a hard time with shots, and they're nervous about it, and then they, especially with this 2-dose regimen, because it's once and then they got to come back and do it again. So how do you make the first experience tolerable enough that they're okay with the second one?
Yeah, so this is a great question, and obviously we do a lot of vaccination in pediatrics, so we think about this a lot. And this is a question that families call in with, even if they're not getting vaccinated at our office. How do we prepare our kids? So I think with anything that's stressful or anxiety provoking, we try to focus on why we do things, what's the positive. So we focus on, this is a preventative measure. Hopefully, from what we know, it's going to help prevent you from getting this virus and keep you safe. We know it's less likely, you're less likely to get the disease if you've been vaccinated. And that may mean also that you're less likely to give it to other people that may be more at risk than you. And that is an important detail. I think that this is my own interpretation of my personal psychology, and I think that it passes along to others as well, which is that I used to do a lot of hiking and leading camping trips. And when I was hiking by myself, I was always pretty miserable when it rained and it was cold. But when I was leading the trip and responsible for other people, I didn't notice that as much because, I had the responsibility for the community that I was with. And I think kids often take that too, when they recognize that they're part of something bigger, that may help them deal with it. I think also from a very specific detail around how we give the vaccine, what we know is that kids in our office who sit there and worry about the vaccine for a long time get more amped up and anxious about it. And one of the things that I saw, my colleagues and I all spent some time at the local vaccine clinic 2 weekends ago. And one of the great things was they had it working so well that as soon as kids walked in, they got registered, they went in, they got vaccinated, and then they were done. And I think that didn't give them a lot of time to sit around worrying about the vaccine. And so registering ahead of time and kind of having your plan in place, I think makes a difference so that you can move efficiently through the process. So those are some thoughts I have. There are some other things like, things that can be applied to the skin. Like we have this little plastic thing that has little dimples on it that kind of creates a little bit less discomfort. And there are some other devices that kind of numb or confuse your nervous system so that you don't feel the vaccine as much. And some kids really like those. Those are other things that sometimes we utilize. I don't know what you think. I actually saw you and Dr. First talk about this a bit. So I'm curious if you have things to add to that.
Yeah, I mean, I think everyone, you all know we all know our kids best, right? So I think in some cases it's we this is a vaccine we've all gotten, right? Or so many of us have gotten. So it's not building it up as a thing like they know lots and lots of like the adults in their lives have received this vaccine and many of their classmates have received the vaccine and hearing a lot from sixth grade teachers saying that as their 11-year-olds in their class would turn 12 they would come in and say like I got vaccinated over the weekend and so making it sort of this community effort and feeling a part of this I think can sometimes be helpful. There's a question here if you can predict in this pandemic, Dr. Josh, what the deal is going to be with masking in children. So the person asked, so right now the state is saying even if you're vaccinated, you should be wearing a mask indoors. So what do we think is going to happen with kids once they get vaccinated? Is there a chance they won't have to wear masks anymore? What do we think?
Um, One of the things that I heard you and Dr. First talk about when you gave your talk was that we need to shift our mentality at this point of the pandemic from thinking about a pandemic that may last for a few months and then be done, to thinking about this as a virus that we're going to live with for years. That COVID is now probably an endemic virus, and that our mentality has been, I think it's been really hard around COVID. Um, I went camping with my kids this weekend, and we went through the town of Conway, New Hampshire. And in Conway, we didn't see more than a handful of people who were masking. But it was a community where a lot of people were coming as tourists. We saw most of the license plates were not from New Hampshire. So we have a lot of different communities intersecting, a lot of people going into stores, a lot of people going into restaurants and enclosed places. Um, and I assume that if there are people who are actively shedding virus during that period of time, that they would potentially put other people at risk. I think that anyone who's talked to me and sees me at my office, they know that we all mask in the office. We know that that's an expectation at our hospital. If you've seen me in public walking into a store, you know that I'm wearing a mask when I walk into a store, or I'm in an enclosed space. And if you know me personally, you also know that if I've had any social interactions with you inside a building, I'm trying to wear a mask to prevent the fact that if I caught the virus at work or something, that I would spread it to someone else. I think right now, I don't have the crystal ball. I know that if we see virus rates drop to where they were in June and July, that masking would not be necessary. We would not see the spread of virus that we're seeing right now. And we know from the research that the most likely place to catch this virus is in an enclosed indoor space around other people when you're unmasked. So for now, in order to try to prevent the spread, masking, I think, is very important. But I certainly hope we get to a point where we're living with this virus as a baseline low rate of virus, and we really can take masks off and interact the way that we were before the pandemic.
Yes, agree. This might be the last question. I'll search through and make sure we kind of maybe tie up some themes at the end. But so there's actually a couple questions about boosters. So you had sort of said we don't know if we're going to need boosters. The adults have needed boosters. In particular, it seems like older adults really need boosters. So again, crystal ball, and maybe you could talk a little bit about childhood vaccines and how often, when you get, say, your 6 month vaccines, those are the same vaccines, right? Or just in a way, sort of getting your second and third dose. So how do you sort of think about that? And what might you predict about boosters for kids?
Yeah. Well, we know that kids require boosters for various vaccines at different stages of their life. An example might be something like whooping cough. So kids are vaccinated at least on the standard schedule um, 5 times for whooping cough under the age of 6. And then we know that although some components of vaccination are very robust and last long times with kids, something like whooping cough, that protection wanes, and so we get a booster as we head into our pre-adolescence. And then it's recommended that people get a booster as they get older periodically in order to maintain that. Um, I think that the crystal ball shows that vaccination boosters for COVID are likely. And that's evident from what we're seeing in terms of immunity and what's happening right now. We do know that kids have robust immune systems and mount strong immune responses, but we don't know how long that immune response will last. And I suspect, number one, because we've seen that the immunity wanes in older individuals, that it may wane in children too. And number two, the Delta variant is here with us right now, but we don't know if other variants will arise. And as we move forward through the endemic part of COVID-19, we may recognize that we need to protect against other strains of the virus, which may require a booster. And that's kind of the way the flu shot works. The flu virus mutates very quickly and changes every year. I think we have evidence that COVID-19 doesn't mutate that quickly at all, but it has mutated, and it has led to the spike in illness that we've seen with Delta. And we don't know if that will happen in the future. Hopefully not, but it could.
I think lastly, maybe we could both comment on, and I can go first, just the general sense of how we think again about risk and benefit. There are a couple questions in here really saying like, what are the knowns? What are the unknowns? Someone mentioned that there hasn't, and this is true, there has not been any child in Vermont who has died from COVID-19. None, zero. We've had no children die in Vermont. So thinking about, what are the risks of infection? What are we protecting? And this kind of goes back to that first slide, like what are we protecting children from when we're recommending the vaccine? And what do we know about, and what do we not know about the virus and the vaccine? So the way I think about it is, there are knowns and unknowns with the virus and with the vaccine. Of course, there are unknowns with everything that we do. Based on our history of vaccine science, based on the millions and millions of people who've already received this vaccine, the unknowns around vaccination are much smaller than the unknowns around the virus. What I really worry about in pediatric patients is how the virus and the infection will affect our kids long term. That's what I worry about when I see kids who, and again, it's rare to have children hospitalized in Vermont from COVID-19, especially in Vermont. We have such a good vaccination rate. It really has protected our kids pretty well. But kids are still unvaccinated kids are still getting sick. And so those kids that, might get admitted with MIS-C or COVID pneumonia, what does their recovery look like? What does their exercise capacity look like down the road? What about those kids with those long-term symptoms down the road? Like, what is the long-term effect on them and their body and their well-being and their development? To me, that is such a big unknown. Whereas with the vaccine, this is like the most studied and followed vaccine, with millions of people getting it. And so we're always honest when we make our recommendations, like what do we know? What do we not know? What are the things that we worry about? What are the things that keep us up at night? We're also all getting vaccinated ourselves. We're vaccinating our own children. So it wouldn't be a recommendation that we would make without, having our own children get vaccinated. So that's how I think about the risks and benefits. And thinking about things like really severe COVID pneumonia in kids or MIS-C or even long haul COVID, and just thinking about that those things are now vaccine preventable, which to me is a big something to really celebrate here. So I wanted to have Dr. Josh sort of end it with, again, your sort of overarching thoughts and how you really, again, it's like a new vaccine. There's tons of questions. Like, how do we think about this? How do we make this choice? How do you talk to families about that?
Yeah, Dr. Bell, thanks. You may not be aware of this, and I'm sure a lot of the people that are on the call today are fully aware that in our community, especially in our local paper, there's been a lot of discussion on the letter to the editor page about the potential risks of vaccine. And there are a lot of people who very strongly feel that we're doing something dangerous and wrong for kids in our community. If people follow that page, they also recognize that myself and a number of my colleagues who take care of kids in the community wrote an opinion piece, which put out a lot of the information that we talked about tonight. That when we take a look at trying to find a balance of pros and cons, that we have strongly recommended that vaccination is a good step for youth. And I, I take this into the context. I think that anyone who can make an argument that everything is bad or everything is perfect is not going to be someone that you can trust. That there is a lot of information that we don't know, and anytime we're making a decision for our families, for our children, we're weighing pros and cons. And I always use this example. Dr. Bell wrote actually an amazing piece early on in the pandemic about how we all assess risk. And as human beings, we are risk averse. We keep ourselves safe by trying to avoid dangerous things, but we also are not very good at assessing risk. And one example of that may be that we, jump in our cars every day, and most of us probably don't think about the risk of being in our car every day. But for almost all of us, that's the most risky thing we do. And we have to make a decision about, does being in a car and the benefits of being in a car outweigh the risks? We know that lots of children get severely injured and die from car accidents every year. But we also know that our children need to get to school. We know that we need to take trips to visit our grandparents. We need to go to sports games. We need to get to doctor's appointments, eye appointments, et cetera. And so we take that risk and we say, I think it's worth it today, even though it's a risky thing to do. And so when I come back to that risk for my family and looking at the pros and cons and what I know about vaccine history and what I know about the data that's available for this vaccine, for myself and my wife, we've decided that the risk is very low in what we know about vaccination. And the benefits are potentially quite strong, both in terms of protecting our children, but also allowing them to participate in the things that really matter for them right now. School, sports, arts, music, visiting their family, trying to travel and do things that we find valuable in a safe way. So everyone needs to come to that conclusion on their own. Anyone who's worked with me knows that I rarely tell you what to do with your children, but I say, this is what I think is the best choice, and this is why. And so I don't know if that's helpful, but that's the way that I think about it.
And lastly, Dr. Josh, folks are asking, are you personally going to be at any of the vaccine community sites, or any of your staff, or is it more your clinic once you get the vaccines that you'll be at vaccinating?
Yeah, so we one of our clinicians was there for the entire first day of vaccine availability at our local mall. We have a clinic that's open on the weekends and then other parts of the week. And we were there staffing, not doing vaccine, but just available for questions the whole time. And mostly it was a social hour. Most families, had already made their decision, made up their mind about vaccinating. And so we got to chat with people, but we didn't have a lot of questions that were asked of us. I think we assume that there's going to be a group of people at the beginning of the vaccine rollout that are very comfortable with getting their children vaccinated. That's what the research shows, that about 30% to 35% of families early on have said, this is something that we've decided to do already. But we also know that there's about another 30 to 35% who have said, we're not sure yet. We need to look at this data. We want to hear from the people we trust. We may want to see if there's been any concerns as the first few people get vaccinated, if there's anything that's been identified as a side effect. And we have assumed that we get a few more weeks into this process that there are going to be more families who are curious and have more questions. And I think at that point, we're hoping that we'll be able to provide some vaccine at our office. We're not sure yet. But if we can't, then what we may do is exactly like you just said, try to staff some of the local clinics so that if people do have questions, they can ask us.
That's great. And I think that was the question behind, the impetus behind that question is um, maybe chatting more with you and staff. Um, would you recommend that folks, you know, it- so one, I'll let everyone know that this is recorded and it's going to be on our website. So feel free to share. I mean, this is like a really challenging time again for families. So make sure to check back our website in the next day or two. The recording will be here and feel free to share it with folks. And then we just recommend reaching out more to your child's healthcare provider to chat more about this. So thank
Yeah.
you all. Yeah, thank you all so much. And I'll give Dr. Josh the last word, but thank you all so much for joining. And again, our website is aapvt.org, AAP Vermont. .org, and all these sessions are also found, I think, on the health department website as well. And I just want to thank Dr. Josh again for his time and his knowledge and experience here.
Thanks everyone for participating. And again, thanks to everyone at the AAP, Stephanie and Dr. Bell for getting this all together. And Patrick, thank you for sticking with us as we ran over in time. Really appreciate it. Have a good night, everybody.